I'm glad that Dr. Murphy is here. She worked with the Venous Stent quite a bit and has that nice article in Circulation. So please, thank you for coming.
Yeah, thanks, Patty. Thanks for the invite. And if you want to pass this down to your so we're going to talk about chronic stent failure, or stent failure in the setting of chronic DVT. These are my disclosures. This is what we can ideally expect in these cases. We're taking patients from pretty dramatic obstruction and presentation to, quite improved flow and certainly a clinical outcome that's much better. All major trials have shown that we're improving quality of life across the board. That's in every major stent trial. But these same trials are showing patency that's still pretty low in this group, and it even drops off further when you get beyond this. And a lot of these patients are pretty young. So what's our patency in this group going to look like at 10 years, right? But why are these stents failing, and can we prevent or salvage them? And I think the answer in most cases is yes. Why these are happening, mostly, I think, is still a lack of understanding of the venous system and the details that we need to pay attention to. People think veins are easier than arteries and that they're more forgiving, but in fact, we're seeing that most of the errors and most of the occlusions are actually due to judgment and technical errors. We actually looked at the Aubrey failures. None of them are due to the actual stent. They're due to inflow issues and decision-making during the procedure. So a lot of docs can be left like this when they're sending us their patients, and we're left trying to fix stents that look like this. A stent occlusion is way worse than a native vein occlusion. So if there's something above the skill set, or you're not sure, you don't have proper imaging at your institution, I would advise sending it to somebody who does, or learning more techniques before giving us this situation, because it can be unsalvageable at that point. The first part is always patient selection, right? So you want symptomatic patients, you want compliant patients. These are elective procedures. Yes, you're making a big difference for the patient, but they're not going to die without treatment. So if you have a patient who won't show up for their follow-up, who's not going to take their anticoagulation, that's not, in my mind, a stent candidate. You need patients who have good, adequate inflow and outflow. You would never put a stent in a patient or bypass from an artery that's not open, right? But you wouldn't believe how often we've seen this done in veins. So you need to have inflow to that vessel. I don't do any post-thrombotic patients, or actually any patients at all, without a CTV and without good iliac duplex and a full DVT scan. You really need to know what your access and inflow is prior to starting the case, and it can limit a lot of complications. This is the kind of inflow study that I get in my lab. Certainly they don't look that good. I wish they did. But the procedural steps each have areas that you can you can pay attention to details to avoid complications. The actual steps do look pretty basic. They're like any other endovascular procedure we do, but it's the details that matter. So we're going to go through those, and I'll show you where the mistakes happen. So vascular access, or access for your procedure, is one of the first steps to make sure that you're going to limit your issues with these stents long term. You have to be able to access and treat the entire inflow. So you got to set yourself up for that. The femoral profunda comes together at that lesser trochanter, around that location. Your GSV is at the bottom of the femoral head. You need to know those landmarks. They're pretty reliable. You can also use your CT to just determine where, in fact, is that profunda. You can actually see it come on, so you don't confuse it with a circumflex or something else. And so you know what you're doing going in. I do typically use mid-femoral access if for some reason I don't want to, because the patient's femoral vein is really bad or their thigh is really big. I'll go in the GSV knowing it's too high to treat the whole vein, do my recan, and then stent from the neck. That's also an easy way to do that. This is an example of what can occur if you don't pay attention to this step. So this patient had an occlusion, had a nice reconstruction. As the IVUS is coming out, you can see going into the catheter, which unfortunately was stuck in the common femoral vein, that it's starting to look narrow right as it's going into the sheath. And this patient, because that lower portion of the common femoral was never treated, actually had a terrible result and has a permanently occluded stent that we've not been able to open on multiple occasions. And they did still have, he's now lost to follow-up, unfortunately, but he does have good inflow even on the ultrasound after the stent occlusion. So if that had been done down correctly stented to the femoral profunda confluence, that would have stayed open long term. So I do use venography as a next step just to give me an overall idea of what is going on and just kind of a clear picture. I don't make decisions based on my venography. For wire crossing, this is a really important step. You want to make sure that you're in the right path. Know that if you're not crossing it, one of the things that's different than arterial, you want to pull your wire back and then re-advance. You're trying to navigate through channels. You're not trying to cross subintimally. So don't be worried about that. Don't be worried about wire perforations. Bring your wire back, redirect. But confirm in multiple ways that you're in the right spot. What you want to see, and actually I'll go back there, is that slow curve across the sacrum and then anterior to the vertebral column. Do not do a reconstruction without getting that picture, especially in an occlusion. This is what can happen if you miss it. So this patient looks a little high, it looks a little acute. When you look at the lateral, it's going right into the spinal canal. There has been some instances of patients having these collaterals ballooned and having bleeding issues and even a death on the table. This is another case that I've now unfortunately seen. This was, at the time I put this in here, it was the first one, but I've now seen 3 or 4 of these cases where these stents have actually been put into the spinal canal. So your lateral will always prevent that. After you know you're in the right spot and you've crossed successfully, then you're going to find your top and your bottom, right? So your cranial landing zone, unless you're doing complex caval work, is your iliac confluence. Use your IVUS. Move it up and down. You'll see the other side come on and off. You can do this with fluoroscopy, but not as accurate. With venography, they can vary by up to a full vertebral body. Ideally, you want your stents to look like this, where they're not jailing that other side. There was a 3 to 10% incidence of contralateral DVT with the wall stent. It probably will be lower with the newer stents, but it took us 15 years to see that, and we have started to see some occasional cases of it with the newer stents. So don't be too rest assured that it won't happen with these. The consequences if you land too high, again, this can be contralateral DVT, as we see in these cases. And the fixing for this stuff is always rather jimmy-rigged. You've really got to get it right the first time. I mean, we're fenestrating through the side walls. I'm not sure this is going to work as well with the new stents. You can also fenestrate in double barrel. You kind of have to be creative to fix them. There's no standard approach. They can also, if they're sitting on the caval wall, like we used to take them, can erode through. So this is one of those cases where it eroded through and then you're occluded. Again, kind of a complex. You can't see the stent, but it's kind of crushed behind and fenestrated. And that guy's never done as well as he could have without that. The one on the other side is if you stent too low, they can watermelon seed back. So you really want to make sure you're getting these lesions where you need them to and that you're using your IVUS. These stents, rather. Distally, you want to make sure you're landing in the healthiest landing zone between the disease, where the disease ends, and you're above your profunda vein. So you do not want to avoid crossing taking your stents below the ligament. In most post-thrombotic cases, you have to do this, but you have to identify your profunda. That's the one mistake that I kind of stopped offering people a correction for because it's too difficult of a fix, especially with the newer stents. You can't fenestrate them. So make sure you know where your profunda is. These are the most common causes of occlusion, leaving disease below your stent edge. And a lot of arterial docs, when they're switching over, they're like, oh, it's not flow limiting. It doesn't matter. It's a low pressure, low flow system. You can't leave that kind of stuff there. The case on the right is a case of that's the only inflow vessel. So there's just insufficient inflow. Landing on a curve, again, if you get that lateral, make sure you're landing in the mid-pelvis for your overlap, or you're landing in a straight portion of the vein. You can jail distal flow, and again, the stents can erode if you're landing on these curves. And so again, the fixes for these can be a little complex. Make sure you're pre-dilating to the size of your intended stents. Don't under-dilate for fear of rupture of these veins. Most of the time, if you're treating a post-thrombotic vein, it's pretty scarred and thickened. You want to aim for normal diameters. For me, that's mostly 14s and 16s in the iliacs. You want to plan your stent overlaps. If your stents are going to fracture, it's going to be at an overlap site and on a curve or under the ligament. So keep your overlap in that straight portion of the mid-pelvis of the external. You want to aim, again, normal diameters. Make sure you're post-dilating. Nitinol, one of the properties of nitinol is you do not have your full strength of that stent until it's post-dilated, and that's true even if you don't gain any size, because gain in diameter is a function of compliance of the vein, not necessarily strength. So you do want to post-dilate, make sure your stent is going to be performing optimally. Afterwards, proper post-op care, making sure you're anticoagulating these patients. Post-thrombotic patients rarely come off their anticoagulation because they almost all have some aspect aspect of inflow disease. And then frequent follow-up. Make sure you're treating any stent complications, recognize them early, treat them early, because the chronic cases are so difficult. Make sure that the patients are candidates, so just because the stent fails doesn't mean you can fix it. If it's a chronic occlusion and their femoral and profunda is now out, that patient really can't be fixed unless it's right at the orifice. Crossing, you're going to need multiple techniques in these chronic cases, because remember, it often looks like this. And then make sure you deal with the inflow if that was a reason for occlusion. So this might be simple as stent extension. It may mean ballooning the profunda. It may mean open revisions or endophlebectomy. So in conclusion, best results with attention to detail, particularly where we have trouble is the landing zones and the inflow. Make sure you know how to properly assess them. Consider long-term anticoagulation, especially if there is an imperfection in your stenting. Sometimes that can be protective. Most complications are preventable if you spend a lot of attention to detail, or at least they're foreseeable so that you know what you're up against. Salvage options are individualized, still a little jimmy-rigged, and not great options overall. So let's, kind of work at it from the front end. Thank you.